Good afternoon, everyone. Myself, Dr. Lepsi, junior resident from SDR Dehradun. I will be talking about the last part of the management, that is management of shock. In shock, we will discuss about the types, diagnosis, and management. First of all, what is shock? Shock is an acute process characterized by body's inability to deliver adequate oxygen to meet the metabolic demand of vital organ and tissue. What are the goals of rapid assessment of shock? First of all, we will look for the appearance of the child and look for breathing and then the circulation. In appearance, we will look for the decreased muscle tone, decreased mental status, weak cry, decreased responsiveness, and purposeless or vacant stare. Failure of a child to recognize or respond to parents or to respond to a painful stimulus is an ominous sign and warrants immediate evaluation of child oxygenation, ventilation, and perfusion. In circulation, pure perfusion can often be identified rapidly before a blood pressure measurement is taken. Cold extremities, mottled appearance, acrocyanosis, pallor may be present. Heart rate, tachycardia is a sign of shock and may be the only sign present in compensated shock. CFT may be delayed or there will be flash CFT. In blood pressure is not required to define shock. Child in shock may have normal, low, or increased blood pressure. Reduced urine output is the most reliable sign of internal organ perfusion. These are the early goal directed therapy. There should be systolic pressure at least 5th percentile for the age. There should be normal pulse volume, equal peripheral central pulses, normal skin perfusion, that there should be warm peripheries, CRT less than 2 seconds, and there should be more normal mental status. Urine output greater than or equal to 1 ml per kg per hour, normal or improving heart rate. Serum lactate should be less than 2 millimole per liter, and venous oxygen more than 70% if available. Now, management of shock. All ill-appearing patients presenting with abnormal vital signs related to shock should be placed on high-flow oxygen by face mask at least 6 liters per minute to ensure adequate sweeping of carbon dioxide from the mask. There should be easy vascular access, fluid resuscitation, antibiotics, vasoactive and inotropic support, endotracheal intubation and mechanical ventilation if required, and there should be control of acidosis. These are the therapeutic endpoints after the management of shock. That CRT should be less than or equal to 2 seconds. Normal pulses with no differential between the quality of peripheral and central pulses. There should be warm extremities. Urine output greater than 1 ml per kg per hour. There should be normal mental status, normal blood pressure for age, and normal glucose and ionized calcium concentration. This is the flow chart. If there are the signs of recognized decreased mental status and perfusion, then we begin with the high flow oxygen and establish intraosseous or intravenous access according to the pulse. And after that, if no hepatomegaly or rales crackles, then push 20 ml per kg isotonic saline boluses and reassess after each bolus up to 60 ml per kg until improved perfusion. Stop if there is any evidence of rales, crackles, or hepatomegaly, correct hypoglycemia and hypocalcemia, and begin antibiotics. If there is a fluid refractory shock, then we begin peripheral IV or intraosseous inotrope infusion, preferably epinephrine, at a dose of 0.05 to 0.3 microgram per kg per minute. Use atropine and ketamine if needed for central vein or airway access. Titrate epinephrine accordingly for cold shock, and titrate non-epinephrine accordingly to reverse the warm shock. If there is evidence of catecholamine resistant shock, and if there is a risk for absolute adrenal insufficiency, then consider hydrocot. Use Doppler PAC to direct fluid inotrope or vasopressor. Then there are 3 scenarios. If there is a normal BP and there is evidence cold shock, then begin milrinone infusion. And if there is a low blood pressure or cold shock, then add norepinephrine to epinephrine to attain normal diastolic blood pressure. If there is a low blood pressure or warm shock, if euvolemic, add vasopressin, terlipressin, or angiotensin. If there is still persistent catecholamine resistant shock, then evaluate pericardial effusion or pneumothorax and maintain IAP of less than 12 msg. If there is still refractory shock, then we will go for ECMO. Thank you.
So, good afternoon again, and thanks for all the presenters today. They were very good presenters and presented details of COVID-19 care in newborn and pediatric patients, and it was all very good, and I think we had almost a good attendance on online also. And these videos, if somebody has missed out on logging on to these sessions, we have taken video sessions, and they will be put on the Google Drive, and they'll be displayed at the university website. And also there's a plan to make a YouTube channel out of these videos, so we'll be floating these videos on that, so in the posterity we can access them if somebody has missed watching those. So this 3 days training sessions on the COVID-19, which was mandated by the NMC, has come to conclusion today. But for the lack of time, we were not able to cover all the topics that were recommended by the NMC advisory. So there were some topics left which needed actual physical presence, which was not possible because of the times that we are in. But some of the topics that needed demonstrations of the mannequins, we will be trying to do those on the next week, also on the online modem, but with the mannequins in presence, so that we can demonstrate some key elements of resuscitations in pediatric and the adult COVID patients. So thank you very much for everybody for logging in, and we wish to join you in next similar sessions on COVID, hopefully next week or next to that, depending on how time that schedule goes. We will give you intimations regarding further sessions, similar sessions on COVID training, which would be done preferably in the skill lab on the mannequins. Thank you so much everybody for joining, and have a good day.